Hello, my name is Ronald Prussick. I am a dermatologist and I work in Washington, D.C. I'm an assistant clinical professor at George Washington University. We're here in sunny Orlando, Florida at the AAD, and I want to welcome you to this program, and I want to give you a summary of what I talked about at the AAD. So my interest as a dermatologist is psoriasis and psoriasis as a systemic inflammatory disease. So we presented some data to confirm that. So I worked with a cardiologist, his name is Nehal Mehta, and he's doing a study, a prospective study on inflammation and psoriasis, and he showed fluorodeoxyglucose PET scans to show inflammation in psoriatic patients, and we're following them yearly with PET scans for 7 years to see if the inflammation reduces as we treat their disease. Some of the other things we talked about were things like fatty liver disease. I talked about how common it is in psoriasis. Anywhere from, the studies show, from 47 to 60% of our patients. So we need to think about fatty liver disease before we actually use the treatments. So we have to think about, does this patient have fatty liver disease before we give them methotrexate or before we give them other medicines that might increase their lipid levels. So we talked about that. We also talked about cancer prevalence in psoriatic patients, the fact that they have an increased risk of lymphoma, lung cancer, and other cancers, specifically non-melanoma skin cancer, squamous cell carcinoma, but not basal cell carcinoma. The studies show, using the Nurses' Health Study, that patients with psoriasis have about a 2-fold increased chance of developing skin cancer, specifically squamous cell carcinoma. And this correlates with the severity of disease. So what we talked about in this session is that most of the comorbidities that patients have in psoriasis, mild, moderate, or severe disease, the comorbidities are increased compared to normal controls, but the prevalence of the comorbidities is increased based upon the severity of disease. So the more severe your psoriasis, the more likely you are to have fatty liver disease, metabolic syndrome, obesity, vitamin D deficiency, psoriatic arthritis, chronic kidney disease, and all the other comorbidities that we talked about in our session. We also discussed that patients with psoriasis are more prone to developing other autoimmune diseases. So recent studies have shown, using a Danish database, that patients with psoriasis develop inflammatory bowel disease about twice as likely as patients who don't have psoriasis. And we also looked at other autoimmune diseases. So the most common autoimmune diseases patients with psoriasis can develop is inflammatory bowel disease, Crohn's disease more than ulcerative colitis, and celiac disease. So those are 2 important autoimmune diseases that we need to think about when we assess our patients. So in summary, we looked at the comorbidities of patients with psoriasis, and there are many to talk about. We need to think about not just psoriasis as being a skin disease and involving joints, but many other organs are involved. And so our future studies need to not look just at PASI scores and ACR scores, but we need to look at other endpoints, including liver function, kidney function, and depression, and other things that our patients with psoriasis are prone to. Thank you very much.